Good morning all, and once again, welcome on behalf of MYT. We're very much looking forward to supporting you with today's test and learn conversation. We'd like to open with a few housekeeping notes before handing over to Leah. We're delighted to also offer today's session in Spanish. You'll see on the Zoom menu bar the interpretation button. Please ensure you select your language now. Thank you to our interpreter for your support today. We'd like to encourage interaction within the session. Please use social media channels to promote and engage a wide audience with this event. Please also be aware that this session will be recorded, and the final recording, along with the PowerPoint, will be shared on post-event on the Health Campaign Effectiveness Coalition website and on LinkedIn. There'll be question time within the Learning Salon. You can either add your questions to the Zoom Q&A, which can be found at the bottom of the Zoom app, or if you would prefer to ask your question verbally, use the raise hand feature and you'll be invited to speak. If you are invited to speak, you'll receive a pop-up promoting you to the stage. You'll then be able to turn on your video and audio and ask your question. Shortly after, you'll be returned to the audience. We will welcome questions in English and in Spanish. Finally, the MYT team are here to help you with any technical difficulties that you may have. Please use the chat facility on Zoom or email the team at events@myt.uk.com. I'm now delighted to hand over Leah to welcome you to the conversation.
Good evening, good afternoon, and good morning, everyone. It is my pleasure to welcome you to the second Test and Learn session hosted by the Campaign Effectiveness Coalition, the first ever partnership for cross-campaign collaboration. My name is Leah Denise Wyatt. I am the Senior Associate Health Campaign Effectiveness Coalition Director and host of today's session. Please take a moment to share which country you are joining from in the chat. The Test and Learn series fosters and facilitates learning across health campaigns and collaboration between health campaigns and systems change. We have a narrow focus on levers within health systems that have been formally and informally tested in a quest to enable collective learning about how to improve coverage, equity, cost effectiveness, and health impact. All common areas of interest among health campaign actors. I would like for us to get acquainted and just gain a sense of the types of campaign activities we conduct. In this poll, please indicate which component of health campaigns you currently practice. And we're just going to show those results. We are logging into this conversation from at least 14 countries, and we represent the full spectrum of organizations involved in campaign delivery, from ministries of health to academic institutions, in addition to philanthropic, non-governmental, and multilateral organizations. And the MIT team, feel free to share those poll results with the group. Thank you. All right, great. We're a lot of campaign planners here, but there's a nice spread. So representatives of the same bodies that I previously mentioned expressed an interest in exploring effective campaign planning in the first annual coalition meeting in October of 2020. Those coalition members surfaced strategies for engaging communities and addressing community concerns as a knowledge gap. Additionally, they conveyed that shared campaign planning tools and approaches can contribute to stakeholder commitment in the engagement process. Today, we join in a conversation with a multidisciplinary team of design specialists funded by the Bill and Melinda Gates Foundation to apply human-centered design and gain insights into systems a polio campaign in Ghana and a schistosomiasis campaign in Liberia operate within. Through this conversation with campaign managers and implementing partners, They uncovered 3 factors that hinge on campaign effectiveness in those settings. They're going to zoom into factors at the community level that intersect with campaign planning and design. As I introduce the moderator, please share whether you have direct or indirect engagement with communities. Our moderator today is Sherine Guirguis, Director and Lead Strategist at Common Thread. Sherine looks for people behind the data. She has been creating powerful narratives with data for 20 years, from leading large-scale behavior change strategies to responding to the Indian Ocean Tsunami, ridding the world of polio, and responding to West Africa's Ebola outbreak. Following the conversation, the panelists will take comments and questions in a learning salon to deepen our knowledge and discover how the insights from this study translate into recommendations and actions. I now turn the floor over to our moderator, Sherine Guirguis.
Hi, everybody. Thank you so much for that very kind introduction, Leah. It's my honor to facilitate this fascinating session this afternoon. Thank you to everybody who's joined. I would like to introduce our panel this afternoon. We have 4 colleagues from the Design Institute for Health who conducted the study. The first person is Taylor Cook, who before joining the Design Institute for Health led an extensive discovery project on homelessness to include people with lived experience and policymaking for the city of Austin, Texas. The second panelist is Caroline Kusi, who is a dedicated social scientist and public health practitioner with over 10 years of experience in global health research and program design, implementation, and evaluation. Our next panelist, Gwen Gage, is a designer at the Design Institute for Health and comes from an industrial design background where her work often centered on issues of global health. And our final panelist, Eratin Hartunian, used systems and civic design methodology to help bring systemic change to the workforce development ecosystem in Los Angeles, California, in the United States prior to joining the Design Institute for Health. Thank you to all the panelists for joining us. So I'd like to kick off today's session by asking the first question, which is, what were you trying to learn through this project, and what was unique about your approach?
Yeah, I'll take that one. Thanks. So the Design Institute for Health's grant with the Gates Foundation started in August of 2019. And what we're presenting here today is just a small fraction of the work we produced about campaign effectiveness. So we hope that this one part of one of our insights is interesting to the coalition as you all plan and initiate learning projects around the world. So based on what we saw in this project, we'd really encourage you individually and collectively to think about the ways that community level factors can be more visible throughout campaign planning processes. I saw that most of you are in campaign planning, so that works out. We believe that no matter where you sit in the system, the decisions you make affect campaign workers on the ground, and you can make a difference in these complicated community level problems. For this project, we wanted to understand how campaigns work in high capacity and lower capacity contexts, and look closely at an immunization and an NTD campaign that was occurring in both countries. So we picked Ghana and Liberia and polio and schistosomiasis because they were scheduled at the same time in 2020. So of course, COVID postponed those campaigns, but we were still able to learn a lot about how different types of campaigns are planned and operate in these radically different health systems. So if we want to switch over the first slide there, we used an approach we called, or everyone calls, human-centered design, which I'm sure most of you have heard of. At the point of impact, it's important to develop a deep understanding and empathy for the experiences and needs of people who are the beneficiaries of campaigns and directly managing campaigns. So we don't start with a hypothesis or seek to prove or disprove it. We have conversations and then follow these emerging themes and threads to understand the system as it's currently operating. So we were able to do interviews and focus groups, thanks to Caroline, miraculously, even during COVID, at the community level. We interviewed leaders and managers at the national and subnational levels, and we also did a final round of research with our global partners and international organizations to make sure that those perspectives also informed the research. So this slide just shows you some of the stakeholders that we were able to talk to and where they sit in the system. And so Caroline, I think, want to talk a little bit more about the systems thinking approach to this project and how it's kind of unique. So Caroline?
Sure, thank you, Taylor. So various frameworks, theories, and methods guide much of the work conducted in public health. And some of these are innovative and new, while others present opportunities for adaptation. Furthermore, in NTDs, social science and qualitative research are relatively new, and as a result, there really aren't any established frameworks outside of M&E for country programs to use to be more effective. With the call to action to help countries reach the last mile, systems and design thinking approaches and frameworks can provide a deliberate and comprehensive suite of tools and approaches to mapping, measuring, and understanding the dynamics within the ecosystem that partners, communities, and countries operate in. So in systems thinking, the systems interact with other building blocks of the health system and are constantly changing with components that are also tightly connected. Therefore, anticipating how an intervention at the community level might flow through, react with, and impinge on these subsystems is crucial and forms the opportunity to apply systems thinking in a constructive way within the health system. So we need to look at how a broad partnership of stakeholders can deliver a richer understanding of the implications of an intervention, including how the system will react, respond, and change, along with what synergies can be harnessed and what negative emergent behavior should be mitigated. We can then apply this understanding to a safer and more robust intervention design and an evaluation that goes beyond the usual input black box output paradigm to one that accounts for system behavior. So this slide, I'd like to talk a little bit about. So it shows the usual conventional approach for identifying problems within the system and ways to address those problems. And then you have the systems thinking approach. And I will just use some examples rather than go through the whole table. But so for example, with straight line thinking, with the conventional approach is viewing causality as running in one direction and ignoring, either deliberately or not, the interdependence and interaction between and among the causes. The systems thinking approach, on the other hand, views causality as an ongoing process, not a one-time event, with effective feeding back to influence the causes of issues affecting each other. Another example would be static thinking and dynamic thinking. So the conventional approach is to focus on particular events. And the systems thinking approach is to frame a problem in terms of a pattern of behavior over time. Okay. So finally, applying design thinking approaches starts with values that look a little like this. Starting the change process with humility, that's number one. Number two, embracing the collective wisdom of communities and partners, committing to equity, humility, creativity, innovation, and empathy. Four, being willing to be open and at times uncomfortable as we seek out the unexpected in improving the experiences of communities. So this may mean asking questions like, what lens is historically excluded from conversations about this problem? What are our assumptions about others? Who benefits from the problem as it exists? What do we know about the context, policies, and history of the community or organization where we are working? And five, recognizing that everyone has knowledge to gain and share.
That's really, really interesting. Thank you so much, Taylor and Caroline. And so what did the study find at the community level, and how would you characterize the main challenges?
Sure. So the insight that came out of the research that we did, or we're going to talk about today, is community level factors are not shaping approaches, but they are shaping outcomes. So we believe that to improve campaign effectiveness, we must not simply be aware of community level factors, but actually make them a core component of future strategies. We found that there is often a misalignment between global level actors' perception of community factors and their actual impact on campaign outcomes and the reality of what happens on the ground. So as a result, many important community level factors are not prioritized at the global level, and current campaign strategies neglect to prioritize major obstacles to their own success. Of course, we don't believe that global level organizations are willfully blind to community issues. Often there are simply few mechanisms to bring feedback from the community up to the global level. So campaign workers and volunteers are especially critical in the fight against diseases and the delivery of interventions, because the success of a campaign really rests on campaign workers' ability to perform their jobs well. However, current campaign strategies do little to support workers and can inadvertently create an exploitative working environment that fails to support workers' safety, performance, and motivation. So one of the things that campaign workers are expected to do is to be an agent of trust for the communities. Frequently, as you can see in this first quote, campaigns address a risk that can feel abstract to individuals struggling with more tangible needs. As a result, campaigns rely on a pre-existing level of trust in the healthcare system to ensure community participation. So trust in and engagement with healthcare programs like EPI or NTDs is also essential to ensure broad acceptance of vaccine information. Campaigns are often limited, though, in their resources for social mobilization and support for building community trust. Some key challenges that we see are the spread of misinformation and growing vaccine hesitancy, for example. And it is harder and harder for workers to persuade resistant families to vaccinate, as we see in the second quote. What used to take an hour now takes 3 to 4 hours and may require several visits. So campaign workers face countless challenges that really jeopardize their safety and motivation during campaigns. In turn, these challenges negatively impact campaign outcomes. Frequently, campaign workers and volunteers must walk between communities under unpredictable conditions, which creates delays, exhaustion, and jeopardizes the effectiveness of the campaign. You can see reflected in this quote that workers are often required to arrange and pay for their own transportation for social mobilization efforts, and they're required to collect campaign materials and carry out the delivery of essential medicines. So I wanted to share this story to illustrate in this community health assistant's own words why campaigns are so challenging and why he isn't able to reach the targets. He noted that sometimes people will be left out of the campaigns as a result of poorly functioning logistics. He explained that to get to his zone by 8 a.m., he will have to go and pick up the vaccines at 7 a.m. But they may not be ready until 10 a.m., which means that he doesn't reach his zone until noon, when most people are already out in the farms and are unable to be vaccinated. So due to their low economic status, campaign workers and volunteers are vulnerable to exploitation. Highly stressful conditions and lack of financial stability lead to frequent staff turnover. The campaign workforce is unstable because of the misalignment between financial incentives and working conditions. While campaigns are often touted for providing financial opportunities to impoverished communities, the reality of that opportunity is more complex. The sporadic timing of campaigns and financial demands on workers may actually fuel financial instability, and high stress conditions have adverse impacts on the mental health and physical health of workers, which leads to high rates of burnout and attrition. As you can see here, this quote is talking about having to use their own cash to enable their work. And here we have a supervisor explaining the effects of such a system, that most workers drop out, which is fueled especially by the low payment for very intensive work. This excessive turnover results in lost institutional knowledge and efficiency as more experienced staff leaves. Staff who are also lost take all of the trust that they have developed with the community members with them. This represents a significant but intangible lost investment for campaigns and the health system. So innovative and effective strategies are needed to improve the working conditions of campaign workers during campaigns. In order to do so, we need to move beyond the individual behavior and performance of campaign workers and move towards understanding the wide range of multi-level factors that shape campaign workers' performance and the ecosystem that they work in.
Thank you, Caroline. That's so interesting. And so I know that this particular study was undertaken in 2 countries, Ghana and Liberia, but I know we've got so many countries online with us today, many people, of course, who have also worked on campaigns. And so we'd like to ask people to just respond in the chat. What on the ground factors have you seen that really determine the execution of a campaign? And you can just put your responses in the chat and we will read them off. I have worked for many years in the polio program and saw many of the things that Caroline just spoke about happening in Ghana and Liberia, happening in Afghanistan and Pakistan. And one of the most interesting things was how the polio program, at least at that time, I've been away for about 5 or 6 years, perceived people's resistance to campaigns. So many people had other needs, as you've mentioned, Caroline. Polio persists in these countries in some of the most vulnerable and marginalized places, and people refuse the vaccine for really legitimate reasons. And there were very, very few people who refused the vaccine, but those who did refuse, or those who were hesitant or who delayed, often weren't perceived with a lot of humanity, I think, from the polio program at that time. They were perceived to be difficult or resistant or obstructive. And I think we've learned a lot since then about people's real lived experiences and how legitimate their concerns may really be. And the point that you made about people having other priorities and them seeing a campaign for a disease many people don't even have a name for, I think is a really, really important point. It's just not a priority. It's our priority, but it's not their priority. So it'd be really interesting to hear people's ideas about how you bridge those things. What do you do when our public health priorities are not community's public health priorities? So I'm seeing a lot of good responses coming in around NTD mass drug administration. Ava saying community members who should receive medicine are away from home working at distant farms. And this also affects vaccinations. What can be done with absent populations? and the need to have continued access to medicines. That's a really, really important point. So maybe we'll hold on to these questions for the discussion, but it's great to see other people's experiences. And I know we've just got one more question, and then we'll open that up and come back to these experiences as well. So I'd like to ask the panel another question. So based on the insights that we've just heard, what do we need to understand to change our systems and address community level factors to improve campaigns?
Yeah, I can take that. So we've created basically a framework to help conceptualize how this information about conditions at the community level flow up to the global partners who are strategizing and funding these initiatives. So we think that by understanding how this information moves, we can ensure that it's properly considered and incorporated into campaign planning in the future. So we're going to be using the term feedback loops to describe that flow of community level information. So you might think of feedback as something that you get in a review or in a conversation with your boss. But in systems theory, feedback really describes when one part of the system sends out a signal to another part of the system, and the signal tells that system how it needs to change or respond differently. So one way I like to think about it is like a pain response. So if you put your hand too close to a flame, your hand sends a pain signal to your brain telling it to move your hand. So those pain signals act as a kind of feedback system to keep your overall body safe. And we've applied this idea of feedback to understand how information from that community level can and should influence the entire system of campaign design. So you can see on the slide, this is the framework that we've created, and I'm going to spend a few minutes going through it because it's a little overwhelming at first. But we've broken down the system of campaigns into these three basic levels of stakeholders. So we have the global level, the national, and the community. And then this gray sort of cone area represents the flow of resources and their value. So here we're representing that the resources put in at the global level become less impactful by the time they reach the community. And that can happen for a variety of reasons. Essentially, what we're saying here is that this feedback from that community level, so the yellow at the bottom, is always being created. So there are trends, there's information circulating, there's always something happening at that community level that's likely important to the way a campaign is designed. And there are basically three things that can happen to that information. So it can either be incorporated into global policies and strategy. So that's the arrow that goes up and in. It can be received by the global level, but not incorporated. So that's the deflective feedback that's kind of going up, but then getting sort of bounced back. And then there's the third option, which is that it's never received by the global level. And we are calling that invisible feedback. So we're going to look at each of these individually. Okay, so the first one, incorporated feedback, this is the one that is sort of data that's coming from the community that's currently being used to design global strategies and planning campaigns. So this tends to be information that is more easily quantified. So things like surveillance data and campaign coverage data. And this data is pretty standard at the global health level. The next one we have, this is deflected feedback. So this is community level information that is known at that global level, but not adequately incorporated into approaches. So this tends to be information that is a lot less easy to quantify and more socially complex. So this is, for instance, many of the things that Caroline just spoke about. So the spread of misinformation, vaccine hesitancy, the high burden on campaign workers. And these issues represent deflected feedback because in our research, we found that there was very high awareness of these problems at the global level. These are things people said they've been hearing about for years, and they were certainly consistent with the literature that was coming out from other studies. But despite that awareness, and perhaps because these issues are so socially complex, they haven't been prioritized in our opinion, like enough in the design of campaigns currently. And unfortunately, just because they are kind of so complex doesn't mean that they're not having an equally high impact on the outcomes of campaigns. So when we did our interviews, we've heard a few different reasons for why these aren't being incorporated. From national program staff, we heard a lot of frustrations around addressing these challenges. So frequently they were told by global partners that such issues fell outside of budgetary parameters, despite their kind of persistent impact on outcomes. And national programs were therefore just had to kind of continue on with addressing them however they had been in the past. And from global organizations, we heard a lot of reasons to explain why there had been a lack of movement as well. Often it was the community level factors had kind of fallen between focus areas that were traditionally funded, so they lacked kind of an existing patron. Organizations frequently referenced that the complexity of country conditions was a barrier, or their own organization's comparative advantage to explain why funding wasn't made available. But unfortunately, these issues, they perpetuate and they continue to weaken the impact of the existing funding. So we kind of hypothesize that failing to prioritize these in the future in donor funding will perpetuate this cycle of loss. And while it's probably impossible to address the entirety of community level challenges, we think there's a lot of subtle ways that campaigns could direct funds or change the way things are designed that would produce better outcomes in these areas. All right, and then our third one, which we touched on a little bit a few minutes ago, is invisible feedback. So this is community level information that never makes it up to the global level, and it's sometimes referred to as the local knowledge gap. So despite not knowing about these things, this feedback and these issues are kind of still happening at the community level and might provide key insights into how a campaign could be designed better. An example of this type of information might be a story we heard from a campaign worker where community members essentially refused to take a vaccine until they received a promised food delivery from the government. So it would be important for campaigns to be aware of other social services running in the same region, and that their ability to implement a campaign might actually be linked to the implementation of another unrelated service. So just to look at the full framework again, we wanted to note that this framework still abides by kind of a legacy norm that global health organizations sit on the top, and then the hierarchy kind of goes down from there. And this is actually something that we heard reflected as one of the concerns about the current structure of campaign design, that there was this top-down approach, probably because of funding. And it can perpetuate this north-south mentality as well. So we think it can be a really interesting exercise if you actually look at the system flipped upside down. So consider in this case, if the community level was really at the top and dictating how things should really be designed to affect them. Just consider how perspective, approach, and outcomes might change if the model looked more like this. And if global organizations sort of took a cue from the communities themselves, how might this affect the priorities around funding? How might success be measured? And what would feedback look like if this is the direction that it flowed? And we recognize that while an actual inversion of this model is very unlikely, it is a useful exercise to consider and to work through to identify sort of the fundamentally different and better approaches to addressing these structural issues that might improve campaigns moving forward. So we're going to take another pause here and give a chance for reflection and conversation in the chat. So this time we're asking you, what are some ways to bring community voices and factors into the planning and design of campaigns? And specifically, what mechanisms might encourage the broadest global level adoption? Because we know that that adoption factor is very key. And while people are responding to that question, I will ask you the same question, Sherine, if you have any thoughts.
Thank you so much, Gwen. that was fascinating. I mean, I love this research. I love that you're asking these really difficult questions. I think so much research asks what's happening on the ground and what's happening at campaigns. And I really love that this research looks structurally, historically, and is asking why do these dynamics exist and what can we do? What can we do to change the dynamics? I think that you're absolutely right. I mean, I'd love to understand from people on the panel if they really do believe that flipping the framework is really ambitious. Is it that hard? Can we do that? Because to me, that's the way I would answer. That's exactly the way I would answer this question, is how can we create systems, I suppose, that can bring the data up. And I think you're absolutely right that human data, social data is complex. And if we can find ways to synthesize it, sometimes epidemiologists really need to see data in ways that they can recognize that is familiar to them. And social data is often qualitative, it's not quantitative, but it doesn't always have to be qualitative. And there's really, really powerful ways that we can mix qualitative and quantitative data, and we can bring that data up with the same speed, for example, as surveillance data. And so one of the things that my company works a lot on, I'm the director of a company called Common Thread. We're a social and behavior change company, and we work on these questions all the time. And we're constantly trying to find innovative ways to bring community level data up into health systems and to make it more digestible and make it more palatable and interesting, I think, for epidemiologists. And I think COVID has in many ways been one of the most powerful advocacy tools for this kind of work, because epidemiologists are really recognizing that you have to bring community voices and factors into not only campaigns, but of course, all of health systems. So those are just some thoughts from my side. We'd love to take questions from the audience. I don't know if Ayrton wants to respond or say something, or are we opening it up to the audience?
We have a bit of time. We could still see if we get any responses. Then I will transition into sharing some of the factors we just found.
Great. Okay, so if colleagues can please put your responses in the chat. Brianna is sharing a paper with colleagues. Thank you, Brianna.
So I will give people some time to chat, type in any factors that they have seen and would like to share. And I'll transition, I guess. We'll share some from our work. So thank you, Sherine, for sharing a little bit about how you approach it in your work. And through this research, there were three factors that we found that greatly affect whether organizations are able to actually incorporate the feedback that's coming and have it affect the design of the campaign. And so those three from our research, the first one is having the right people. So hiring and having representation from professionals that have experience and knowledge from social sciences. And also the other individuals that are in global health organizations to become more comfortable over time with qualitative finding and realize that they do also contain as much important information as quantitative data does. And then the second factor that we realize affects it is whether people can take risks and fail in a small way. So not just risk aversion in global health when it comes to financial accountability or the risk associated with health outcomes, but do program managers and people at the global level feel safe enough to take risks and try some innovative approaches on a small scale? So how do they feel in their safety of their reputation to listen to community feedback and then use that to actually design their next rounds of campaigns? And then the third one that we believe really affects it is kind of addressing the stakeholder relationships between that global level, national level, and the community level. So there is power imbalances there. And one of them is that the type of feedback that they use first and foremost is the traditional academic research that gets priority above all. And we heard that only after considerations from published research have gone through, maybe they would consider local context as information that helps the design of the design of the campaign. So those were the three factors that together, I think, with some of the suggestions of how you could actually go about creating more of a culture and openness to really consider those feedback that's coming up from the community factors.
Great, thank you so much, Ayrton. So we're now transitioning to our dialogue, to our salon. So we'd love to invite people to ask the panel any questions that you may have. Please use the Q&A function in your at the bottom of your screen to submit a question, or you can just raise your hand and speak. We'd be happy to hear from anybody who wants to either contribute to the dialogue, contribute to the conversation, or ask a question. There's always got to be somebody to break the silence. Does anybody want to be first? Okay, David. Okay, so David is asking if virtual platforms have been used effectively in helping engage the community level in campaign design. Connectivity is always an issue, but access to mobile phones down to the community level continues to expand. Has including community level thought leaders virtually in district and national level discussions on campaigns been considered or documented as being effective? Anybody want to take that from the panel?
I can say that I haven't heard of much, but this is definitely not our area of expertise of the like virtual platforms being used. I know that we read several things about them being used in the actual by the campaign workers to kind of streamline that process for them. So looking at the campaign worker burden. But one thing I would say is, I think this gets in an interesting question, which is one issue that I think we sort of saw is that there's really a difference between having that content and incorporating that content in a very real way and letting it direct how things are going to work. And so a lot of times, you know, people will be like, oh yes, we heard from the community. It's very important that they trust their community health worker and that it's someone from their community. But then we would talk to people, you know, who had worked as community health workers, and they're not working necessarily in a community that they're familiar with, or there were other barriers. So it still seems like there's a disconnect between actually hearing that information and truly saying, okay, we're going to change the way we've run things for 25 years and actually, you know, do it a little bit differently. If anyone knows of an example of that, that would be great to hear.
Yeah, I don't know of an example, but I just wanted to follow up. I think, you know, that's the kind of innovative solution that I think we would be really interested in seeing y'all pursue. So I think just, you know, ways to get some of that kind of feedback and get community level people more incorporated in decision making. And of course, the technology and expanding use of technology offers some new tools and some interesting, potentially innovative things that the coalition could try.
Great, thank you. There's a really great question from somebody who is anonymous, who's asking, have you found any examples of where power imbalances have been evened out to allow for community level innovation, and what factors allowed that to happen, and how was that recorded? So when have campaigns sort of overcome those power imbalances that you've found?
I will say that we heard an example, I can't remember where it was from. I think it was Tanzania, but it was an example of a pilot program that had run around polio campaigns that had specifically built in this structure to have greater engagement with like local leaders. And this is like something I feel like everybody references that would be great to have, but this one, they had really gone out of their way and built these strong relationships, had those community leaders really involved in the process. so that then once the campaign was kind of going, they were a voice for that. They were an advocate for the campaign to their community, and things were sort of more smoothly run, and they saw quite a good result from that, and people were really engaged in the campaign and so on. And then I believe the outcome was that the funding was cut and they were unable to do that program anymore, which was very disappointing because it had been so successful.
That's a shame. I know this is not from your research, but I know that there is a lot of research on onchocerciasis and how that's been done by the Carter Foundation and other organizations, of course, including WHO and others, and they use community-directed or community-designed intervention, CDI, and that is an enormously successful program that really places the ownership and leadership at the community level through mass drug administration. And they've had a lot of success, and that is almost completely administered from the community themselves. So if people don't know about that program, you might want to take a look at that, because that is one program that has shifted the power imbalance, at least from my limited knowledge of it, and it has had really great coverage data. So I'll just turn to another question, and if colleagues want to raise their hand or speak up, please feel free. It'd be great to hear other voices. But just going in the chat, Brianna's asking, one of the primary goals of the HCE Coalition is to bolster opportunities for campaign integration and country ownership. I'm wondering if you can reflect on how a shift towards these integrated approaches can provide opportunities to improve on the inadvertently exploitative working conditions for community health workers. Anybody want to take that?
I can say a little bit, but I feel like Caroline might have something to say on this one too. So I think, so the shift towards an integrated approach, meaning like integrated campaign delivery, I think that would certainly, I could see how that would certainly help, because you're not creating a competitive like market in a sense, if people are more just employed by a group rather than having to pick between campaigns. I think the biggest thing that would shift that exploitative working condition, though, is a decision and a mental shift to really like treat these workers as employees, and to give them the support that they are asking for. I think just because something's integrated doesn't necessarily mean that there will be an inherent change in the support for transportation or training or the stipend that they're given. And those were really the things that we heard created the exploitation kind of situation, rather than simply being between campaigns, if that makes sense. I'm not sure if somebody else wants to add something to that.
I would, and it actually connects a little bit to what Gwen was presenting earlier on about retention of community health workers. It's also connected to a previous question about what's a good way to really bolster the community level feedback. Well, community health worker programs have been a good, whether we've seen it in Liberia, there's been some in Ethiopia, great examples where there is a really strong pulse with the community health workers. They really know what's going on and are able to better collect that what's going on in their local context, either bring it up to the national level campaign program or at the global level. And so, but those community health workers or those campaign workers, the longer they are, the longer they work in the job, the more they have that local context knowledge and know the patterns and what will work or what not. And so how to address them when the workers do get feel like they can't continue with the job anymore, and when they leave, they take with them that kind of local knowledge as well, and it actually further deteriorates the ability to stop exploitative conditions, because those who have experienced it long enough are no longer there to stand up for their experience as community health workers and stand up for it. So each new round of community health workers that come in are having to, whether it's intended or not, relive that experience of in an exploitative working condition, and kind of the cycle continues on without stronger advocacy building up for their work and the communities that they work for. So I don't know if that directly answers, but there's a correlation between how quickly workforce changes and what they could actually do to strengthen their workforce.
Great, thank you. I know also from my experience working in India for many years is that once polio was eliminated from India, there was a huge workforce that was quite anxious about what they were going to do. Were they going to lose their job? And just even explaining that there was a new sort of initiative, which was to eliminate measles, that created a lot of motivation. People felt like they had a career path. People felt like they could still continue on. And so even just showing people how an integrated system can support their career development, I think can make a huge difference. So thanks for that, Ayrton and colleagues. So I think this will be the final question. Well, there's two questions. Maybe we can be really efficient. I'll take the first one, which is having done some research talking to decision makers within campaign planning, there is often a lot of different types of data they have to process and synthesize to make a decision. Sometimes the decision is made through group consensus. Other times a decision is advocated for with the final decision made by a decision maker. Your work mentioned multiple possible data streams and factors to consider at the community level, but how should a decision maker prioritize the relative weight of different data? If you have competing data, have you found any good tools or frameworks to prioritize action or decision outcomes? It's a great question. Anybody want to take that?
That's a really good question. I don't know if we have found any specific frameworks of how to prioritize the data. I think that's actually one of the sort of unsolved answers or unsolved questions, which is which data is actually going to give you the right formula, the secret sauce to get the response you want. And I think our perspective is sort of things have kind of been designed in the same way and function the same way for several years. So we haven't had a lot of chance to see how prioritizing different data will get a different result. So in this case, I think the ideal would be if there was smaller scenarios of like pilot programs or in like a very specific region, if you could try running a campaign or designing a campaign around by weighting the scales a little bit differently, by prioritizing something that you wouldn't normally way more than something else that you would normally rely on, and just sort of testing that hypothesis of what sort of outcome do you get? Did it improve the outcome? And then I feel like that sort of proof of concept is really needed by the people designing and running the campaigns in order to sort of elevate this conversation to the next level.
Yeah, Gwen, I think you're right. I think it would depend on just more dynamic planning and having some different solutions depending on what the community's needs are, because we know every country is different, and then when you get down to a more granular level, every community is different, and even subpopulations within that community might have different needs. So it's not going to be a one size fits all.
Okay, great. Thank you so much. We have one last question. Thank you so much to all of the participants for your participation. And I'm so sorry if we didn't have time to get to your question. But we'll just ask one more. How could working conditions be adequate for workers to complete their campaign work and be seen as sustainable from a country government perspective?
Sorry, I can chime in on that. I think as we discussed, there's a lot of factors that impact, the mental health and also the on-the-job experiences for community health workers. And when you talk to program managers on the ground at the district level and at the regional level, it always points to, in my opinion, money, which is tied to the implementing partner and then tied to the donor, right? And so you often hear program managers complain about there's no money, so we can't. So, for example, community health workers are given a certain number of households to reach. This is for at least LF and uncle cirrhosis. And so they're given these households to, and within a certain number of days. So they might have 4 days to reach, I don't know, 500 households. And then you also have to think about, okay, number one, them retrieving the medicines. And then number two, moving from household to household, which sometimes require out-of-pocket expenses. So all of these combined really at the core has to do with funding. So could, the implementing partner for Ghana, let's say, could they invest more money into providing more transport money, for example, to community health workers? So there's different factors, but I think the way to tackle it is to really work with the implementing partner and the donor at the global level and say, you're giving the country this much and this is what they're able to do. But, if they had this much, then the campaigns would be more effective. So in short, I would say the donor, the implementing partner, all have to be convinced that this is an issue and requires investment of money. Otherwise, it's just business as usual. And then they're walking in heat as well. And some of them even experience men chasing them away, et cetera, et cetera. So, and also how do we incorporate mental health coping mechanisms and trainings into community training, trainings for community health workers. So far, I don't think that in a lot of countries they've thought about including that component into their training. So that's another way to help them with that. And then I think I talked about the number of days for so that, the burnout, could we reduce the number of households, but that would mean more days of paying per diem. So it's really a conversation between the implementing partners and the donor, because the programs will just say there's no money, right? So I hope I answered the question.
Thank you, Carolyn. That was great. Well, we're just about at time. I know we're just a couple minutes over, so my apologies, but thank you so much for your participation. Thank you for the wonderful work that the Design Institute for Health carried out and for the really rich research results that you've contributed to this space. Thank you so much. I'll just hand over quickly to Leah to close. So over to you, Leah.
Great, thank you. Great conversation. So I should mention that the Health Campaign Effectiveness Program just announced 8 awards focused on campaign planning for integrated health campaigns. The recipients are based in 6 countries across South Asia, Sub-Saharan Africa, and South America. The awardees will develop a case study on collaborative planning, pre-implementation, and the negotiation phases of integrated health campaigns that answer questions such as what criteria or other factors do campaign managers and decision makers consider in identifying the campaigns and geographic areas where an integrated campaign might be feasible. Another question is, what does the stakeholder or the agency involved in campaign planning see as potential benefits or challenges of an integrated campaign? What are the metrics for success? And the third question is, what approaches and processes are used to initiate and foster dialogue among government and partner organizations in actively engaging stakeholders in the planning process? what enables or hinders this collaborative planning process. So we are and see and have an opportunity to dive right into the conversation, or what came out of our conversation today, and how stakeholders are engaged right at the outset. So I want to thank you, Sherine Guirguis, and to the Design Institute for Health team for advancing the conversation on health campaigns and community engagement today. And thank you to all the participants on the call for advancing the conversation. So really quick, just tell me, did you learn something new today? Did you learn something new today? And I'm going to give you a second to answer that question. And I have a second one for you. So for future planning, please tell me what topics you'd like to see in the future. What topics would you like to see in the future? So I think that poll is coming up. Yep. So help inform the Test and Learn series moving forward, please. All right. So as a reminder, the coalition, the Health Campaign Effectiveness Coalition, is a cross-campaign coalition. We're fostering learning and systems change that supports implementation research that advances testing and replication of evidence-based health campaign practices. The coalition develops guidelines and approaches that help campaigns and practitioners improve their collaboration with country health systems. So thank you for your input into future subjects for the Test and Learn series. Materials will be provided via our social and website, our social channels and website. I do invite you to save the date for October 19th and 20th of this year for the annual Health Campaign Effectiveness Coalition meeting. Again, that is October 19th and 20th of this year. You can continue the conversation on campaigns and community engagement via LinkedIn. So find us on LinkedIn if you're there. You'll see links to the materials announced there. You can also connect with us on Twitter to continue this conversation. If you would like to have or send a direct message to us, you can find our email address on our website. So I hope you all have an excellent rest of your day and your week. Stay safe, wear your mask, wash your hands, and watch your distance. Thank you so much, everyone. Have a great day.